What I'm going to present to you is a tissue-engineered regenerative medicine trial where we're completely hopefully, are able to regenerate the complete lower urinary tract for patients that have bladder cancer that undergo radical cystectomy. These are my disclosures. Importantly, I will discuss results of a clinical trial sponsored by Jian, and this work, and some of the work that I'll present is funded by the NIH. So as it relates to radical cystectomy, once again, I think Jeff's done a great job of setting up sort of the issues related to that. Really, when we think about bladder cancer patients, what type of surgical innovations have been made in the last 50 years? You know, we talk about lymph node dissection, impact of lymph node dissection in patients that have had a cystectomy, and hopefully the SWOG trial will put that question to bed soon. We'll have the results of that shortly. The studies out of Europe have not shown a benefit, but nonetheless, you know, that is one approach to surgical innovation, excuse me. The introduction of the surgical robot into radical cystectomy practice, the randomized controlled trials would suggest that it's not superior, it's not inferior, it's comparable. So I would say that we not really made much progress there. My group and a lot of groups have published on the utilization of ERAS or enhanced recovery protocols, and I would say that that's probably made some of the biggest impact as it relates to the perioperative period for both physicians and patients, but we still have a lot of room to work with. But what about urinary reconstruction? What's been done? Well, this is sort of a basic outline of urinary diversion for congenital abnormalities as well as for cancer. And you can see that we've really not made a lot of progress over the last 20 to 30 years. We're still utilizing the Studer or the Hauptmann neobladder. We're still doing a Bricker conduit. And really the point here is that we're still using the GI tract. And I would argue that the utilization of the GI tract is what impacts and causes some of the profound catabolic effects that we've heard about in our earlier lectures. And if we could stay away from that, we may be able to prevent it. As it relates to bladder cancer management, the two most common urinary diversions are a ilioorthotopic neobladder as well as an ilioconduit. In the United States, about 20,000 ilioconduits are done annually, whereas 1,600 neobladders are done annually. This is actually comparable to what's happening in Europe. So if we're going to make the biggest impact in our patients, we need to be able to come up with a better form of reconstruction as it relates to an ilioconduit or a loop, and this would impact the greatest amount of patients that we're working with. As I stated already, the complications related to cystectomy within the first 90 days are all related to, or the majority are related to the utilization of the GI tract. These are just some examples of what can happen, but what question we really have to ask is how can we get away from utilizing the GI tract? So we've hypothesized that actually the complications associated with this are from the urine being absorbed by the GI tissue as well as the bowel utilization. So if we could figure out a way to come up with a tissue-engineered approach to regenerate a conduit, could this prevent our patients from using the GI tract? This is a concept that has been proposed for the utilization of augments of the bladder, in particular the bladder and urethra. This is work that's been done both in Germany, throughout Europe, as well as in North Carolina by Tony Atala. But the issue is that they're actually using biopsies of the patient's own bladder or muscle, and we can't do that with patients with urothelial cancer for the obvious reason. So we've actually proposed that we can figure out a way to isolate smooth muscle cells and then implant this onto a urinary biodegradable scaffold. I'd like to make the point here and pause and say that what we're proposing is not the utilization of stem cells. This is the utilization of fully differentiated smooth muscle cells. So this is a differentiated, say, terminal cell. What others have in other fields have used is stem cells because they're pluripotent. They can become any cell type. However, we are not interested in that because we are dealing with patients with cancer. And we thought that potentially the microenvironment would predispose a stem cell seeded scaffold to potentially become cancer. So we're utilizing a fully differentiated cell. This is the first sort of series of experiments that we did to show that we can actually isolate smooth muscle cell that is molecular and genetically and histologically similar to that of urothelial, bladder smooth muscle cells from both peripheral blood as well as from a fat biopsy. So this is actually just the characterization of that. So we could actually isolate a fat and be able to make smooth muscle cells. We introduced this concept back in 2013 that we might be able to use a fully seeded scaffold with smooth muscle cells isolated from fat. So this is actually the schematic that we came up with at that time, and I'll go over this more in detail. But the thought is that there was a company named Jian, which is the same company that did the augments out of North Carolina, and they were looking for a different indication. Mark Schoenberg, who was at Johns Hopkins at the time, was actually at a meeting not too dissimilar from this, and actually saw a presentation where they were talking about other indications, and actually spoke to him. I'll explain why I got involved later. But the thought was we could do a fat biopsy, we can isolate adipose-derived smooth muscle cells, expand them in vitro, seed them onto a scaffold, and then after a cystectomy, we could then implant this into our patients. So here were the challenges that we had. We had to come up with ways to be able to provide a blood supply to the biomaterial that was seeded with our patient's smooth muscle cells. Where could that blood supply come from? It could come from the peritoneum. It could come from omentum. The other approach that we thought about, but are now doing in our future trials, is that we could actually genetically modify the smooth muscle cells to overexpress growth factors that would actually bring in more angiogenesis. But that's sort of version 2. But here we were going to use peritoneum or omentum. The biomaterial, this is the #1 mistake that we made. The biomaterial that we chose was actually the material that was used in previous trials. And the problem is this is a PLGA scaffold that actually degrades quickly. And when placed around in urine, it actually induces a robust inflammatory response and actually could actually cause less engraftment of the tissue. We learned that from this trial, and I'll show you the data, but that was the #1 mistake. As a young investigator, I didn't question it. And what I should have done is I should have said, wait a minute, let's look at different materials and come up with the best approach. We also talked about ureteral implantations. We ultimately used a Wallace anastomosis, and we thought that this may be a developmental challenge. The development of the stoma was actually the part that we didn't put much thought in. Once again, another mistake. And that ultimately became one of the biggest barriers. And I'll go over why that is in a second. So first we did this in a porcine model, where we actually did this in a model in a pig where we did a cystectomy and then did ureteral implantation. This is actually just a schematic of how we did that. Number 3 problem is that when you do a preclinical study, make sure you're doing your preclinical studies in a model that recapitulates the human condition. In a porcine model, these pigs were actually were on all fours. They were not standing up. They're not moving their body. So once again, the importance of preclinical modeling comes to truth here. Here you can see that they are standing upright, and we brought the Neo-Urinary Conduit, or that conduit that was seeded with smooth muscle cells, to the skin, but it was on the abdominal wall. It wasn't coming through the rectus muscle. And here's the example of how that was done. Here's your ureters going onto your scaffold that was wrapped with a peritoneum in this model, and then it came out to the skin. The results of this, if I just showed you this picture, you would say, wow, you've completely regenerated every portion of the urinary tract. This is showing that they developed urothelial lining consistent with cytokeratin positive, which we see in the bladder. It developed calponin and alpha smooth muscle growth, and it actually developed neoangiogenesis. So we were able to regenerate urinary tissue with this approach. And here, once again, pretty pictures. But the reality is that we were able to make muscle and make urothelium. But what we didn't recognize is the functionality of this. And this is retrospectively looking at this data, you can learn a lot. This is actually serum creatinine and kidney size by ultrasound, essentially looking at hydronephrosis. If you look at group 2, which is what we did in the humans, you could see at 4, 8, and 12 weeks, you see this sort of steady rise in creatinine, as well as steady rise in what is essentially hydronephrosis. What happens is that in this model, when you bring this to the outside, actually what we were seeing as early as 12 weeks was contracture at the stoma and what was not allowing urine to come out passively, and therefore you saw this backup. So another mistake that we made was we didn't look at this at 6 months, 9 months, 12 months, okay? Believe it or not, with that data, the FDA approved a phase 1 clinical trial. This is a phase 1 trial, which is a safety trial. This is only looking at safety, not efficacy. So they approved us to do this in 10 patients. I was the PI at Johns Hopkins. Gary Steinberg was the PI at University of Chicago. And our thought was that we could do this in patients that had muscle-invasive bladder cancer or BCG unresponsive disease, and we would make them a neo-urinary conduit. This is the demographics of our cohort. As you can see, these are patients with muscle-invasive disease. 3 of our patients received neoadjuvant chemotherapy. The rest were BCG unresponsive. A lot of our patients had very advanced disease, lymph node positive disease. Others had adjuvant chemotherapy. So your standard sort of cystectomy cohort. We had 8 patients in the trial, 7 men, 1 woman. The indications are here. The length of stay for the trial was 5.6 days, but what I will tell you right now is that these patients were literally looking at us on post-op day 2 saying, why am I here? I don't understand. It's kind of like them undergoing an open radical retropubic prostatectomy. It was amazing. These patients had no concept of what a post-cystectomy really is. They were eating and drinking on post-op day 1 and looking at us and asking, what's going on? We had to keep them in for 5 days because that was part of the protocol. 3 patients actually died in the trial, 2 from bladder cancer as well as 1 from an MI, which I'll go over. We actually had to explant all of the neo-urinary conduits due to contracture of the material with stomal stenosis, which ultimately led to obstructive uropathy. The lifespan was 250 days, with the shortest being 42 and the longest being 484. What we did was we did a fat biopsy on the abdominal wall. We then isolated adipose-derived smooth muscle cells in the lab, seeded them onto a scaffold, which is PLGA, and then we implanted it into our patient's post-cystectomy. This is actually at the first cystectomy at Johns Hopkins. This is me. You can see this was prior to me actually undergoing this trial. This trial aged me probably 10 years. This is essentially us wrapping this with omentum at the time of our surgery. The reason why I got involved is because they recognized my background in stem cell biology. I actually did a PhD in stem cell biology. So as a cystectomy surgeon and someone with that background, the thought was, would I be able to sort of help advance this and get this into clinical practice? The pathway was implantation using the Wallace anastomosis as I described. We wrapped it with omentum. The first 2 were done with peritoneum. We used ureteral stents and a stoma catheter, and these were removed at 4 to 6 weeks, and the stoma catheter was removed at the discretion of the surgeon, and I'll show you that data. Unfortunately, we had to explant all of them due to stenosis. So here are the clinical results. This is the final results of the trial. The first 2 patients done at the University of Chicago, we used peritoneum, and it was not adequate blood supply. The patients developed ureteral leaks into their belly, had a contracture, and actually went explant and ileoconduit within essentially the first 3 months. So our initial approach that we sought to do was not effective. So we then brought the next patients were at Hopkins. We then moved to Omentum, and with the utilization of Omentum, we actually were able to get some patients out to close to a year or more. This allowed us to have the good blood supply. The problem was the Omentum was not adequate blood supply to supply the distal aspect of the neo-urinary conduit at the skin. So the stoma became an issue. And some of our patients actually passed prior to us needing explant. That's what those 2 are. So the 2 patients at Chicago were explanted immediately due to peritoneal. And our 3rd patient at Hopkins, when we used Omentum, actually was actually doing really well. And then when the stents in the stoma catheter came out, she developed acute flank pain. And actually, smartly, she took a catheter and catheterized her stoma. And I have a video that I think will show why she did this. She was a very smart lady. This is actually the stoma. Importantly, you can see it was very small. This is a ureteroscope of the neo-urinary conduit. If I showed you this, you would say you probably look like you're scoping a ureter. Here, this is actually the scaffold that wasn't able to be removed due to the fact that it was contracting. And when we get past the scaffold material, you can see we actually are into the conduit. You can argue that this may look like a primitive urothelium, one that's been exposed to maybe an infection. And then, bam, we're at our Wallace anastomosis. Here's our 2 ureters where it meets. This thing went from being 12 centimeters to approximately 4 centimeters. And this contracted within a short period of time. So why did this occur? This occurred because of this. This is our 5th patient. Here's our stoma on day 2 with Omentum wrapped around it. Here's our stoma catheter. But by day 28 and day 43, the body is essentially just healing. It's a wound, and the skin is starting to grow over. And what happens is, as soon as you take out this stoma, it then contracts more and you develop obstructive uropathy. One of our patients, we decided to actually keep a stent in for the entire time, and actually they were able to go out until 16 months, and then we had to remove the stent, and guess what? He contracted and developed obstructive uropathy. So what is the histology? The histology is important because it does show the success of this exercise. This is the patient at 7 weeks that died of a myocardial infarction, not related to bladder cancer. And you can see as early as 7 weeks, we're already developing smooth muscle that grew. And you're seeing early urothelial lining that's cytokeratin positive. This is a patient that we explanted at 10 months. This is a patient who had carcinomatosis and had a bowel obstruction. I brought him to the operating room to do an X-lap and to essentially alleviate the bowel obstruction. And I explanted their NUC because I realized that this was actually a potential cause. He had nephrostomy tubes in. It wasn't working. At 10 months, we've got beautiful lined cytokeratin positive urothelium, and we've got a beautiful muscle. And if I showed you this picture, you'd probably say that looks like a ureter. So what this showed us is that we were able to regenerate all aspects of the urinary system, including nerves. So we actually were able to regenerate nerves in our patients. So in conclusion, we were able to successfully regenerate urinary tissue. However, the translation of technology from preclinical to actually clinical results it wasn't functional. This thing contracted, it was not compliant, and caused obstructive uropathy. So what we've now done is, and this is where my lab has moved, is trying to come up with a better approach to be able to do this again with a version 2. And I'll show you just how we're doing that. We've changed our scaffold. We're now using a collagen-based scaffold that has more compliance. We are now using 2 cell types, one that is going to promote angiogenesis and one that's going to promote better urothelial lining. And our vascularized pedicles are now going to come from 2 different sources, the omentum as well as from the abdominal wall, to help alleviate the stoma. This is my acknowledgements. I thank my co-investigators in this trial, as well as my team in the research lab that are hopefully going to advance this to the next step. Thank you.